Next on primary care, what federal health care cuts could mean for Detroit and families across Michigan.
About 300,000 of those people will have all their benefits eliminated, and about 200,000 will have them reduced.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. Today, we're taking a closer look at the health care cuts in the One Big Beautiful Bill. It's a federal budget proposal that includes major changes to Medicaid and other public assistance programs. Changes that could affect access to care and the basic support families depend on to stay healthy. Current projections estimate that nearly 500,000 Michiganders could lose their health insurance coverage. Proposed Medicaid work requirements, changes to food assistance, and reductions in hospital and public health funding could reshape how and whether many residents receive care. For many families in Detroit and Wayne County, this goes beyond insurance. It touches on food security, housing stability, utilities, and the everyday resources people rely on to manage chronic conditions like high blood pressure and diabetes. Joining us today is Dr. Herbert Smitherman. Dr. Smitherman is the Associate Dean of Community and Urban Health at Wayne State University School of Medicine and President and CEO of Health Centers Detroit Medical Group. He has spent more than 2 decades building primary care systems in underserved communities. Dr. Smitherman, welcome to the show. It's about time.
Okay. Thanks,
Good.
Dr. Joe.
Herb, we've watched this thing develop over the years here in Detroit, and all of a sudden, well, across the country really, especially the kind of things you're involved in, and all of a sudden we're up against a wall with something called the Big Beautiful Bill. For the listening audience who basically don't understand what that means, what is the Big Beautiful Bill?
So it's a piece of legislation that was passed in July of 2025, and it's largely spending cuts at the federal level in a lot of safety net services. So healthcare, Medicaid, significant cuts, almost $1 trillion over 10 years. SNAP or food benefits.
Trillion with a T.
With a T,
Mm-hmm.
That's a T, trillion. About almost $300 billion in food benefits for Americans, housing reductions, transportation reductions, child care, education. They made significant cuts, probably a total of about $1.5 trillion in spending cuts, so that they can transfer that into tax breaks for the most wealthiest in our country. So it's the largest wealth transfer in the history of the country. But, you know, a lot of the people who are getting these huge $1.5 trillion in tax cuts really don't need them. The people we're talking about that are losing food, housing, health care, transportation, education, child care, whatever you want to name, every social service, safety net service is being cut. These are people often on the margins, and the difference between the extra $170 a month in SNAP or food benefits may be the difference between their children eating and not eating. And right now, Michigan has 1 out of 6 kids. Remember, 1 out of 6 kids are hungry every day. Every single day. When you're cutting the kind of money that they're cutting out of SNAP benefits in the state of Michigan, I mean, you're gonna have a lot more hungry families, a lot more hungry children. This is not who we are as Americans. We don't beat up on the least of these, on the most vulnerable in our society, to give people tax breaks that they don't need.
So from a Michigan standpoint of view, in particular Detroit standpoint of view, you just mentioned SNAP. The average SNAP benefit, as we can calculate it and estimate in this community, is between $6.50 and maybe $7.90 a day to eat off of for food. I mean, that's going to be affected. No, is being affected with these changes that we see coming out of Washington now, which basically have to come through Lansing, which means more cuts locally.
Yeah, so, you know, the average, probably in Michigan, food benefit for a family is like $170 for a month. $170. Now just think about that. And we're talking about cutting that significantly. So can a family live off of, let's say, $100 a month for food? Is that what we are as Americans? Is that who we are? Is that the kind of ethic and morals we have in this country? I don't think so. We have come together because we understood after the election in 2024, there are several physicians, you know, you involved, a lot of people involved, came together and began having conversations about legislation we were seeing coming down the pike, which ended up being the One Big Beautiful Bill. Yeah. But as we saw this, we got together and began, this is Wayne State faculty, Wayne County Medical Society, DMS physicians, Detroit Medical Society. We came together and said, what are we gonna do? When these cuts start happening, we can't just sit and watch our communities be devastated. What can we do to protect them? And so we have brought together many leadership across the county and the city to try to help mitigate that.
Do we have the numbers correct? The estimates in Michigan, 500,000, 500,000 people are going to be affected by this. How realistic is that number?
It's probably underestimated.
Underestimated.
Because with Medicaid, they're talking about with the cuts to Medicaid for the state of Michigan, which are about $1.1 billion with a B, and probably about, you know, maybe $200 million, $300 million for SNAP. They're saying about 500,000 people on Medicaid and about 500,000 people on food benefits, which we have about 1 million people on food benefits. About half of them will be affected by this. About 300,000 of those people will have all their benefits eliminated, and about 200,000 will have them reduced. It's 500,000 people that are basically on the margins, that are significantly food insecure, that we're talking about cutting those benefits. And we're trying to find, at the state of Michigan, how do we fill those gaps? How do we fill the cuts that the feds have, that the Trump administration has placed on Michigan? How do we fill that gap? We have right now, about $1 billion. I'm talking about the 2025-2026 budget, the budget we're in.
Right.
We are running right now at about $1 billion deficit in Medicaid that we're trying to figure out where that money's going to come from.
So we're just waiting for the tsunami to take place.
The tsunami is here.
One of the things that is here, we're not even floating yet. Okay?
Yeah, right.
So one of the things that have been mentioned in the bill, as it's known, is the work requirement for people who currently on or trying to get on or to qualify for Medicaid assistance is that you got to go to work. Now, we know of 3 states here in the country that have tried that, 10, 12 years and abandoned it also because it was cost prohibitive. People monitoring the people to show up to work and the amount of money that was spent cost the state of Arkansas 7 times, what they were spending on Medicaid, and they quickly abandoned it to say it doesn't work. Where is this going in terms of how we're approaching this here in Michigan now?
Well, in the month of February, the country lost 92,000 jobs and up. And those number of jobs, the loss of jobs and the loss of available work is going up. Many of the people that are on these kind of support services are disabled, they're aged, the educational level is poor, the kind of jobs that they're able to get are menial jobs, they're not around. So you're trying to force a largely disabled population who is marginalized to find work in an economy that's downsizing, that's losing jobs, and the administrative burdens, as you just said, are significantly weighty to try to even monitor a system like that.
So even though they're working, they still need the assistance, is what you're saying.
Yes.
And that's being cut.
And even if they temporarily lose that job, they even need the assistance more.
Even more.
Yeah. And so you have to have a piece of legislation that when it says you have to work, we have to have available jobs for people. You know, the reason they're in trouble is because the education level is poor. They're disabled. They're older population. They're talking about trying to get a job up to age, what is it, 64?
Right.
I mean, you're 60, you're gonna start a job, where are you gonna go?
Right.
And you may be disabled, you don't have an education, blah, blah, blah. There's a lot of literacy issues within this. So we have a social safety net for a reason. And as you alluded to, many of these people are working. It's about 90% of the population is working. Now you're just trying to have an administrative function to keep track of it. They have to monitor it. A lot of these people don't have computers. They can't go online and log their hours, et cetera. You know, that's where churches and other people are gonna have to come in to say, hey, they need an internet. They need a computer. They need all of these resources. They need to know how to use a computer so they can enter their work hours and their data.
Right.
Where's all this happening? You just made a law. You made a law that there's no infrastructure to support the law.
A law that is doomed to fail the people it was intended to help from the beginning.
Yeah.
We need to go back to some of the boilerplate discussions of the definitions of public-private partnership. To think that the private sector is going to be able to handle an overload of this kind of services is not practical. And to think that it's all going to be supported by governmental funding, we need to figure out how we get communities involved so that these lack of services can be provided in a way that supports the community as a whole so that we can reduce some of these healthcare disparities that we continue to suffer from. Because right now, the way that we're approaching this means more bureaucracy, less service.
And like most Americans, we already feel like we're taxed out of the planet. I know you feel every day for your job, your business, your private practice. I mean, we are taxed over the moon, and still it's not enough. And as you take my tax money, you then say, well, I want you to solve the problem of society through the private sector.
Right.
Well, what happened to my public sector dollars?
Right.
You know, how are you spending those? Like Doge and all these other people in the federal government, they're talking about waste. Oh my God.
You know, we were talking offline earlier about how the leadership factor has to take the role in doing this. And some of the problems that we've had with schools of public health as we attempt to put one at Wayne State around the country, and I know this might get a little bit political, is that there has been a lack of leadership in that arena. If you look at how public health is designed and who should be in the forefront and the leadership of that, it should be the voices and the experts within those systems that come out to fight these kinds of industries. Instead, we've been suffering from the lack of that kind of leadership around. We have one school of public health in the state of Michigan here at University of Michigan, and even though the relationships might at times have been good, we still are behind the curve in terms of the pulpit, the bully pulpit that they have on some of these issues. We don't hear those voices. We don't hear that kind of approach. I mean, published in another paper doesn't get the job done when you need to be standing up in public, saying the right words to the right people so that we can make change. That's why we get bogged down in the administrative cost of doing this. I say all of that to say that where are we in terms of turning the corner on this? Because I've been to 1,000 conferences on this issue. I feel that way, at least, on these issues. And we wind up the same way. We were discussing how a lot of that discussion gets lost in the mix. We can't even find the verbiage sometime after we leave the association or the situation that it was mentioned in. Where are we in terms of turning this around? You mentioned that it's going to take, you know, a different approach to deal with something like the cuts coming from the big, beautiful bill. Where is the public voice that actually puts this out here in the public domain?
Well, first, the public voice has to vote, okay? So we just saw in 2024 when 5 million people who voted in 2020 didn't come out to vote. And the results are you got what you got. And then you end up with one big, beautiful bill.
Why am I complaining?
Yeah, right. I'm going like, you have to vote. There's an election coming up in 2026. That has to happen. But to your question about public health, I can tell you, and I don't like to talk about this, but the state of Michigan, we haven't really funded public health at a rate that's consistent even with other states. As you saw with COVID, public health was underfunded and we could not respond properly, properly to the COVID pandemic.
Right, the term impotence comes to mind, okay, to do that. Herb, we need to take a break.
Okay.
Stay with us. We'll be right back after a short break.
Substance use disorder and addiction is so isolating. And so, as a Black woman in recovery, hope must be loud. It grows louder when you ask for help and you're vulnerable. It is the thread that lets you know that no matter what happens, you will be okay.
Welcome back. We're here with Dr. Herbert Smitherman, Assistant Dean of Community and Urban Health at Wayne State University School of Medicine and CEO of Health Centers Detroit Medical Group. Dr. Smitherman, you are stimulating my juices, as my grandmother used to say. You trying to scratch my itch on a lot of these topics because they're so important, so germane to the functioning of this community that we as practicing physicians are supposed to serve. We were just talking about the numbers overall, and you were mentioning the budget cuts. Go back to that and reiterate a little bit in terms of how you see these cuts really affecting us.
So Governor Whitmer recognizes we don't have enough resources in the public health infrastructure of the state of Michigan. She has a public health advisory council. I'm a member of that council, and we are trying to come up with policies to increase spending in public health. If we were to have a pandemic right now, we would not be
Couldn't
ready.
handle it.
Yes. If we spend on public health per capita in our state about $83. The average in the country is about 120. So we have a long way to go to get our public health infrastructure up and strong enough to handle some of the issues that may face our state and our nation. We need to collaborate. We need to take that public health infrastructure and better collaborate with the other health infrastructure like hospitals, primary care, pharmacy, dentistry. So we need to build it up, first of all, stabilize it, and better collaborate and coordinate with other parts of the healthcare infrastructure. And we are trying to do that, setting policy to actually do that. But it's got to be funding increases, and we got to prioritize that.
Okay, well, but you and I have been around the block a minute in this discussion.
One or two.
Yeah, with various entities, the physicians, the healthcare systems, the insurance companies. This is deja vu now. You know, the older we get, we're reliving the discussions even. We just don't have the movement. There's been no progress to actually reach some of the endpoints that you just spoke of. Where are we at? In particular, how does this relate now, coming off of the COVID pandemic? Did we learn anything? I mean, we weren't ready for it.
No.
It was a disaster in itself. I mean, and like you just said, if we get another pandemic now, you know, did we learn anything that's going to help us get through the next one? Because something's coming. I think something's coming.
Yeah.
Even if it's another bill out of Washington, like a pandemic, it'll be coming. Yeah.
Right. Yeah. So over the last several decades, we have continued to erode the funding of public health in this country and in our state. And yes, it impacted on our ability to respond to that pandemic. And yes, we did learn a lot. Now the question is, as we have learned a lot and people are talking public policy to correct our mistakes, those public policy changes require funding.
It costs money.
It costs money. And government spending is about how you prioritize that money. So, you know, we talk about roads, we talk about water, we talk about all kinds of infrastructure needs. Those are needs that we have. You know, I busted a few tires on the roads in Michigan. But we also have other priorities that are life-saving. And in my opinion, I think the way we help prioritize how our government tax dollars are spent is called voting and participation. Is being active in the process. We had a conference quite recently where we brought Senator Slotkin in and all kinds of leadership across the county, the city, the state, and we are talking about ways to find better funding, to better collaborate, because once you find the funding, you're going to have to be much more efficient with with the use of those dollars, and that's going to require collaboration. You can't be in a silo over here thinking that you're going to solve housing by just HUD, by the housing and urban development. You've got to partner with healthcare. You've got to partner with business. You've got to partner with transportation. I mean, you got to partner with education, because you're trying to move people out of public housing into well-paying jobs. We have to better collaborate to make the dollars that we have, the expenditure of those dollars, those limited resources, much more effective.
Generations before us seem to do things differently. They did a better job with a lot less, so to speak, than what we have now. When we look at budgets, especially healthcare system budgets, we see dollars spent in various arenas. We've gone from community-minded clinics 60 years ago to safety net hospitals, and now safety net systems in order to take care of communities around this country. How are these cuts specifically going to affect hospitals in the metropolitan Detroit area? And I ask that because for years we had the underlying prevailing thought out there was that DMC would take care of it. Okay, and I'm calling names because you need to, number one, and it needs to draw in all of the people who have a stake in healthcare of a community like this. So how are these cuts going to affect hospitals who actually have the burden of taking care a disproportionate share? That's an old term we don't use anymore. Right. Disproportionate share of people who need a majority of services.
So we do not have a public hospital in the city of Detroit, but we have hospitals with public missions. Mm-hmm. And let's just take Medicaid, and you're talking about facilities, nursing home community. Mm-hmm. Medicaid covers 63%
all the nursing
all
costs.
Medicaid residents mm-hmm. in the United States, 63%, and covers 70% of the cost of all nursing home care, mm-hmm. which is about an average of about $100,000 a year. And so if you now are going to assume that full burden of your loved one mm-hmm. that's in this nursing home.
You got sticker shock.
Right. Now, mm-hmm. 70% of those dollars are covered by Medicaid. Mm-hmm. And now you cut Medicaid by $1 trillion with a T, as you reiterated. Okay, so the implications are, where are these loved ones going to be? They're going to be at home. You're going to be taking care of them. What is it going to do to the workforce? Somebody's going to have to stay at home with them. The cost out of your money, you're going to bankrupt people. The system can't take it. So safety net hospitals disproportionately get Medicaid dollars. When those resources dry up, that means you don't have the resources, the facilities, the prescriptions, the doctors, the medications, the surgical equipment. You don't have the things to appropriately care for your community.
So this twin disease state that won't go away in terms of discussion, high blood pressure and diabetes,
yes.
Patients in a community like this,
yeah.
with those two disease states, are going to be mostly affected by these kinds of cuts.
We're going to have more heart attacks, more strokes, more death, and more preventable deaths.
Right.
So you're just going to see that what's going to simply happen. I hate to say it, but people are going to die.
So we'll be experts in counting the numbers,
yeah.
not providing the care.
Right. Just like in the COVID pandemic, we were counting.
Right.
Until we got a vaccine, we were just counting, brother.
Right. So basically, there is a domino effect. There
yes.
is a spectrum-wide effect
mm-hmm.
that will occur from decisions like this being made mm-hmm. in Washington. Mm-hmm. If someone loses their Medicaid coverage, okay, what is the immediate effect to that person, for that person?
Well, they can't afford the hospitalization. Mm-hmm. The number one reason for personal bankruptcy in the United States is healthcare costs.
For 14, 15 years in a row now, something like that.
It's been there for a long time.
Long time.
But mm-hmm. it will bankrupt a lot of Americans. Mm-hmm. They will not be able to afford their diabetic and hypertensive prescriptions. They will not be able to go to the doctor because they have no insurance, they can't pay for the visit.
And we run a free clinic where we hit the wall very quickly with a patient like that. Mm-hmm. I mean, I'm not going to be able to keep up on any disease state unless I can treat you like I treat somebody with insurance. Mm-hmm. Okay, so these patients not only get shortchanged by the system, they also get shortchanged by people who are trying to do a public good and a public service, because we can't meet a standard of care in a setting like that for that patient who has these common diseases like high blood pressure and diabetes, more heart attacks, more strokes, more deaths.
Yeah, and the burden on the primary care physician who's already having their reimbursement slowly decline. So your money that when you see patients, I'm talking about your commercial insurance, when you see those patients, your revenues are already going down. Now they're going to shift a lot of the uninsured, because you're now going to make a larger part of the population uninsured, which is now going to also, they're going to transfer that burden to the primary care physician, which is basically going to devastate the primary care infrastructure in the United States.
Remember Nancy Reagan?
Yes. Said, just don't do it. Just say no.
Just say no. And the flip side of that was, what is your community doing to help you on the healthcare end? We kind of missed that because drugs took the, all the headlines at the time. But the flip side of that coin and that conversation that she had publicly in front of cameras was, what is your community doing? Is your block club doing anything? Is your church doing anything? To say, go back to your own state and say, what are you doing to help this? Well, here again, you said it earlier, without those resources, without a business approach to a public issue, you're not going to have a good outcome. And that's what has not occurred, that public-private conversation, even though they're occurring, they don't produce. And I think, like we were saying earlier, we just not have had the leadership, local, state, nationally, to actually say, this is where we need to be to achieve outcomes. We function in an outcomes-based environment for healthcare now, especially in medicine and how everybody wants to give you a report card. And we think we're going to achieve that without outcomes-based accounting, okay?
Or investment.
Outcomes-based investment,
Yeah.
outcomes-based leadership. People are settling for failure in an environment that really costs lives.
And all I think Americans want, Americans in general do not want a handout. What they want is a functioning government that provides them a little support so they can transition in a democratic, capitalistic society to a job, to help pay for the reasonable resourcing of my family. People want a little help, not. And it's 20% of the population. They need a little help, and they can keep moving forward. What we're doing is keep putting pressure on the middle class.
Exactly.
We're burdening them with more taxes, less resources, and we're pushing them down into the lower class, and we're making those who are wealthy even more wealthy. We are devastating the middle class in a country, and in a capitalistic democracy, that is an extremely dangerous position to stay in, because democracies are held up by the middle class.
Right. That's why we put training wheels on bicycles,
Yeah.
so that you can learn how to ride on your own.
Yeah.
Dr. Smitherman, we're out of time.
Oh.
We're going to continue this.
Okay.
I promise, because this is an exciting. I've got 1,000 questions left here to ask you. But
Okay.
here again, thank you so much for coming. This has been outstanding. Great.
Always.
Excellent.
Always.
Our guest has been Dr. Herbert Smitherman, Assistant Dean for Community and Urban Health at Wayne State University School of Medicine and President of Health Centers Detroit Medical Group. Next time on Primary Care, we continue this discussion with Dr. Smitherman, focusing on what families can do and how providers can help. For Primary Care, I'm Dr. Lonnie Joe.